Steph, are you gonna have stuff to share? Or is any of your group gonna have stuff to share?
Just his case. I can do some work for once.
No.
JD, do you have anything that you need to share?
Just criticisms of Steph if everybody wants to hear them.
Do not be mean to our trainees.
Steph.
You have to be nice to me.
Okay. And I have to make sure that I'm still logged into. It might have logged me off. Okay. Oh, look at that back. Oh no, it's ready. Okay.
As we're getting set up, Larry, I don't know if you can see this big 60-some kilodalton, 60 kg beast that we're dialyzing here, but we're probably going to do tandem dialysis on it on Friday. So see what you're missing, being retired, all this fun stuff.
What's tandem dialysis?
We're just run 2 dialyzers simultaneously.
Oh, like a tandem bike?
Yeah. Yeah.
Yeah, that's really cool. What's wrong with the dog?
Yeah, it's only like 3, but we're worried it might have an acute on chronic, but the chronic has not been known prior to this. Has a creatinine of 10, BUN of 120 or so, feels pretty miserable.
Do you have all the adapters for the splitters? Do you have all the splitters to?
Do. Sure do.
What kind of dog is it? What's the breed?
St. Bernard.
Okay, I can see the face now. Got it.
On Friday, I think we have RR on Friday. I wonder if you ought to be. Will you be ready to show it then?
Yeah, we'll be treating.
Okay, we'll pull you in then.
Can't wait.
Okay. Welcome everybody to December rounds, and it looks like we've got a good crowd here. So that's always exciting. And before we start, again, we have a generous volunteer from Friendship Animal Hospital to discuss one more of their cases. And so, but please, I like this to be a group collaboration. And so if you have a case or a question about a case, and even if it isn't the entire full case, but you want to briefly discuss something during these sessions, then feel free to send me an email when I send out the case request. And it doesn't have to be a full lengthy discussion. We can always just hit a quick topic if you need to. Also, if you've noticed you've been kicked off the list and you haven't gotten an invite from me, then please reach out or let somebody else know to reach out to me so that I can put you back on the list. Again, I say this every month, but we don't know why. Sometimes Outlook just accidentally removes people from our distribution list. For example, Dr. Hokamp has been removed from our distribution list, and she is actually the person at Texas A&M who I work for. So I don't know how that happened. And then we are recording them. We are doing a little bit better about uploading them to the ACVNU YouTube channel. Summer has put the last couple ones on. And so if there is a discussion, she does a little brief summary of what the diagnosis is at the very beginning of the link, or what you click on. So that way you would know, oh, this is an AKI case, or this is a Lyme nephritis or something like that. So you could at least, if you wanted to listen to a specific topic, you can also do that. And we have the next year coming along in January. I assume these time frames still work for everybody. If there is an overwhelming need to change the time frame, I can consider that. This actually works best for me because it's my day. I don't work for my other biopsy service. But I would be happy if there is, if this just is a time frame that isn't working for anyone. But it seems to work for Friendship, and since they are our biggest contributor, we might just leave it with that. We might be the ones that make the final decision on that. Anything else that anybody knows coming down the line for future sessions or future discussion topics? Dr. Nabedy and Dr. Hokamp, I know you have probably a quick announcement about biopsy availability during the break. Do you want to speak about that?
I don't know if Jessica can talk.
Okay.
Yeah, so basically,
I can talk.
Okay, I'll let you take over then.
Sorry. I can talk. I just don't know if y'all can hear me. I'm down in the EM lab.
We can hear you.
Okay, y'all can hear me. Okay, so we will be closed from December 24th through January 1st. Those are A&M's closure times. And this is due to the fact that the labs that we utilize to be able to get our diagnostics done will also be closed. So just be cognizant of that. And also, since the 23rd is Monday, if at all possible, if you've got anything that y'all need to, they try to make sure that it gets to us by Friday of this week so that we can get y'all something. Additionally, because labs will be closed, anything that we get this week will probably have a bit of an extra delay on it as we come back into the new year. All of that said, I'm on clinics all of the holidays, so I will be available by email if I need to answer any questions.
If things are shipped, will they not get delivered? Like, is there like a complete blockage of your delivery?
No, except for the
could you ask
actual
me a question?
holiday.
Okay.
Like, except for Christmas and New Year's, we cannot accept anything on those days.
Okay.
It would get totally delayed, and we're not sure about the days before each of those days. But
Okay.
otherwise, there's at least somebody in receiving where the package should arrive. Now, whether it gets
To you guys.
refrigerated and handled
Yeah.
appropriately and to us is a different question.
Okay. So for the clinicians on the call, if there is something that needs to be done urgently, it should be done this week. And if you have, for some reason, you need to get us material and it is during the week of Christmas, it's best to give us an email so we can further direct you. But it really, honestly, no results are going to come quickly until the new year starts again. So let's hope we can give you as much information as we can on the samples that we already have. Okay. JD, do you want to discuss your patient, Ramona?
Sure, absolutely. So I have a 2-year-old, kind of a bit, she's a bit tortoiseshell. She's not complete tortoiseshell, but she's a bit torty. And she came in through primary care for evaluation of maybe not eating all that great. They had thought she had some super erupted teeth, and they were concerned about getting her to get a dental. And so they ran some pre-anesthetic lab work on her. This is the first set of labs. Actually, that's not true. She had some lab work a year ago, and 1 year ago, she just had a CBC performed, but that was overall normal. And she was FIV negative. She does have a history of, she's from Spain. That's where the owners adopted her. And she lived in Spain for probably at least the first 6 to 9 months of her life. So it wasn't as if she was just adopted and brought over. So she was there for a while before coming here. We do have values from October of 2023, where she had a creatinine of 0.9, a BUN of 20, an SDMA of 12, FELV, FIV negative, and of course, we are not going to have a urinalysis on that visit. So she at least did not have any elevation of her kidney values in a year ago, last October. So at this most recent visit, when she was being evaluated for her teeth, her pre-anesthesia blood work was performed, and she was found to be azotemic. Her creatinine was 2.9, her BUN was 65, her SDMA was 30. She was hyperkalemic at 5.9, hyperphosphatemic at 12.9. Her albumin was on the low end of our normal range. It was 2.3. The low end of our range goes down to 2.2. And she was hyperglobulonemic at 5.4. The upper limit of normal is 5.1 for our lab. Interestingly, going back to her lab work a year ago, she was hyperglobulonemic at 6.5 a year ago, but that would have been when she was probably when she first arrived here from Spain. So she would have been under a year of age at that point. She's been FELV, FIV tested negative multiple times. Her urinalysis on this most recent visit, before I get to that, she was also anemic. She had non-regenerative anemia of 25,000. She had a leukocytosis of 23,000, which is mostly actually lymphocytes, probably equal parts lymphocytes and neutrophils. So that was a bit unusual why she has this lymphocytosis. Her platelet count was normal. Her blood smear that she had at that point showed that there was nothing that was that really all that significant, that there was some mild toxic change to her neutrophils. There was some type of chronic inflammatory lesion that the pathologist suspected based upon her leukogram and the appearance of everything. So, non-regenerative anemia, lymphocytosis that's characterized by really the lymphocytosis. Her neutrophils are technically normal, but about the same magnitude. This azotemia, hyperglobulinemia, and her urine, she came back with a USG of 1013, pH that was 6, 3+ protein. She did have 30 to 50 red blood cells, no pyuria, no bacteriuria, a negative culture, and her UPC was 10.6. So with that information, she was referred to come see us for discussion of where we go next. So I guess I'll just pause there. So we have a less than 2-year-old cat, UPC of 10, creatinine of almost 3, lymphocytosis, hyperglobulinemia. I guess I will open it up to questions, thoughts, comments on what people are thinking, where you might want to go next with this.
Any stomatitis in this cat?
Yeah, so I kind of was thinking about that as well too, with this, the mouth and lesions there and concern for needing to get a dental. I was pretty unimpressed by the magnitude of stomatitis that was present. In the same breath, I will completely admit to my ignorance of not being that proficient, though. The mouth maybe could be aflame and I might not notice it. So nothing that was obvious. And certainly the dental was more for some of her changes to her teeth rather than the nodation of having severe stomatitis. But maybe a dentist would appreciate more than what I'm appreciating.
And then I always ask about the paws, the paw pads, pillow foot.
Yep. Totally normal.
Were lymph nodes fine?
Yep. Lymph nodes were fine. No problem there.
Okay, let's see. What else? Is there anybody else who has any other questions about this case? I'm assuming when you did your analysis, you got the proteinuria, but there really wasn't anything active in the sediment.
Correct. Just there were 30 to 50 red blood cells. There
Okay.
wasn't dysmorphia that was reported, but I would not trust the IDEX lab tech to report that.
Okay. And we got your analysis. We got urine, obviously, from whenever you submitted the sample, and I'm not sure if we saw anything. I can quickly look and see if we saw anything in our sediment. So.
Right.
Okay.
So when I saw her at this point, I was mostly concerned that there could be a chronic inflammatory disorder. We had the hyperglobulinemia that's really been present both times her labs have been checked a year apart. She has this history of maybe poorly described oral problems. She has this non-regenerative anemia, which is a bit more significant than what I would expect for a creatinine almost of 3. and this lymphocytosis. So I thought the anemia was maybe even more so due to anemia of chronic inflammation, maybe anemia of chronic infection. She originates from Spain, so I wanted to do my due diligence, and we submitted for leishmania to make sure that that wasn't a component, and she did end up testing negative for leishmania. We did some imaging, which showed nothing that's all of significance. Her kidneys didn't look that bad. They weren't really all that chronic. They had some mild changes, some decreased corticomedullary definition. Otherwise, it looked like we had a good window to biopsy them. And I recommended performing a biopsy because I was concerned that she might have an immune complex glomerulopathy because of whatever was going on systemically. That was also contributing to the hyperglobulinemia, the lymphocytosis as well too. So the owner was on board. We placed an E-tube. She was eating fairly well, but I knew that we were going to throw some complications with medications and whatnot on board as well too. And the owner was very concerned about medicating her with her oral discomfort that she thought she had. So we popped in an E-tube and we collected some percutaneous ultrasound guided biopsies to submit for analysis.
Okay, let's see. So, in the interim, and I guess this just is reflective of the kind of contact that we have with a lot of the clinicians that use this regularly. We had some communications from JD about concern about this case and this patient in general. So we got the samples. I was able to text him. Excuse me. The prelim kind of right as I was looking at it. So if there is a scenario, a lot of you guys that are on this call use us regularly as your pathologist. So never feel intimidated to reach out to us. And I'm realizing the sun is blinding kind of right on my blinds on my face. But I'm actually in sun, so I'm very happy about that. I'm going to pull up the H&E first. I do see we have a few pathologists on this call. So I want to give them an opportunity to look at the images first. And of course, it's now telling me which one do I want to do, not Excel. I want to show window. Teams has changed. Oh, here it is, never mind. Okay, you should be in a, hopefully now you're seeing a core. Are you seeing a core?
Not quite yet, but it looks like something's trying to load.
Should I try again?
Maybe. Yeah, I still don't see anything.
Okay. Whenever they do an update, things always kind of, wait, turn what screen? Maybe what screen?
Yeah, that worked.
Okay, cool. All right. So we got two really good cores. I'm going to quickly scroll through them so that the pathologist can kind of get an eagle eye view of what's happening. Obviously, clinicians can as well, but this is kind of a survey view for perspective. We got two cores. They actually had this one was mostly cortex with a little bit of medulla that I'm circling on this edge. The other core was actually mostly medulla and a little bit of cortex. And as we always say for biopsying cats, the kidneys are a little bit smaller of a window. And so it isn't uncommon for us to get medulla in some of these samples. It's not our goal, but it actually can be pretty helpful for the diagnosis depending on what the disease is. So,
and Rachel, this is the one that I actually texted you that photo of the actual biopsy. So can I share that actually with everybody?
Let me do that. Yep. You should have permission, but tell me if you don't.
Okay, let me share screen.
And then JD, can you just comment on how easy it is to get these biopsies in cat? I struggle recommending it because I just feel like these kidneys go away from us. And just kind of just talk about technique maybe.
Yeah, sure. So this is a pretty small cat. She's only like 2.7 kilos. Is my my screen sharing for everybody?
Yep.
Okay. I'll see if I can zoom in a little bit as well. So she, yes, is a small little lady, but we have a good window that we could identify with ultrasound, and then we use our the needle guide to guide the angle so that we can also double check that we are happy with the overall depth of tissue that we have when we biopsy. And as Rachel said, with cats, you almost always get medulla as well too. It's hard unless their kidneys are enormous or you have a big like Maine Coon to get something that's only going to be just cortex altogether. I'm just gonna open that up in a different program. This will be easier. Here we go. So the other thing that we do is we do look at this tissue right away. So this photo is through our dissecting microscope that I'm evaluating at the time that we collect it. And you can see all of these really nice parallel lines, which are all the medulla, and then this splotchy area, which is, you know, about 50%, we can actually make out the glomeruli that are there. And I think if you don't have the ability to evaluate the tissue in real time, you're going to have a much greater chance of having samples that, you know, are maybe even more medulla. And depending on how well your patient's doing, you know, if I only had half of this section, well, I want to make sure that I'm getting enough representative samples. And if we have if you have a glomerulus that's completely sclerosed, well, that doesn't tell us what the disease process is. So imagine some of the glomeruli you are sampling potentially could be non-diagnostic because there could be sclerosis. So I might get an extra core if I had a really small sample in general. So this is just with your typical dissecting light microscope, which everyone used at some point during like biolab probably. You can get them pretty cheap, and it's just a very important tool for us. So we evaluate all of these biopsy cores immediately after we collect each one, and then we are working with our radiologist to say that was a good one or that was really mostly medulla, and then we might talk about how we can get a different angle, or maybe we switch to the other kidney. Maybe that might have a better window for us. So it's a very interactive process when we're actually trying to collect the tissue that gives us the best chance of having a diagnostic sample.
JD, there's a
What was the gauge of the needle? And I'd also make the suggestion that in these cats where the kidney tends to push away when you try to get your sample, you can actually, in almost all cats, you can have somebody hold the kidney for you, yeah, so that it doesn't move.
Yeah, and that's a good point, Larry. We often will need to brace the caudal aspect. We do our biopsies under anesthesia because we often find that if you could hold their breath, the diaphragm can also provide some cranial bracing. So between the diaphragm and your hand, you can stabilize it. With cats, we generally use an 18 gauge needle. For dogs, anything other than maybe a very small cat-sized dog, we're going to use a 16 gauge needle for biopsying. So this is an 18 gauge needle that we use.
JD, there's a request to circle the glomeruli one more time, and I think that's also why you can see the glomeruli a little bit better than maybe a 16 gauge is 18 gauge. I think it's thin enough you can see it better than the thicker 16 gauge core.
Oh, that's not what I want. I just want to draw a line. Here we go. Oh, I can't even see that. Sorry, I'm trying to do something as we speak.
As you're figuring out how to draw a circle, Steph, do you want to step in and make fun of JD for this? I bet Steph could draw a perfect circle.
He does not need to. Okay.
So
I don't know that he's very technologically advanced, which is why he's struggling so much right now.
Oh my
Yes,
God.
you want to know Phil for that. Okay, but as Mary said, the 18 gauge is going to be a tiny bit smaller so you can see through the core better. However, when we looked at this analysis in dogs, not cats, an 18 gauge is more likely to cut a glomerulus in half or not capture an entire glomerulus. So we still recommend if you're at a dog or you have a larger kidney to get to, if you have the ability to get 16 gauge, that is the best opportunity to harvest entire glomeruli with like a little bit of tubular system around it. It's just based on the size of the gloms. So, but when they are a little bit thicker, they have a much thicker caliber. They are going to be a little bit harder for that light to penetrate.
Yep, absolutely.
Okay.
So yes, like, you know, the gloms that you can see are just these, oftentimes a paler divot amongst the tissue. Occasionally the background tissue might be more pale and you can see the glomerular capillaries be a bit kind of red, but this is what I find is the most common appearance, that we'll see these pale splotches, which is very different than if we are to look at the medulla. We're just seeing all of these parallel lines and you're not seeing any of those splotches whatsoever.
Okay. So if we coordinate that, we have that region of cortex, and then we go, I have to do the one sharing the screen now. A second, hold on. Okay, not yet. Okay, so that means I have to do this. Share window is what we realized. Oh no, share screen is what we wanted before. Okay, hopefully you guys are seeing the core again. Yes?
Yep.
Okay, I see JD kind of
Yes.
nodding. Okay, so
Yes.
So again, so we had regions of medulla, we had regions of the cortex, and again, letting the pathologists kind of get their minds oriented to where the glomeruli are. The other portion of cortex is a little bit better, but I do want everyone to see these dark blue nuclei out here. So we do have a bit of interstitial nephritis. And in this part, it's mostly lymphoplasmacytic. Here, mostly lymphocytes. We got a few plasma cells in here. And so it is kind of separating the tubules from one another. So we have a little bit of evidence of kind of chronic disease. This is only a 2-year-old cat, so this would not be expected in a normal kidney from a 2-year-old cat. So everybody can kind of see the dense blue nuclei. And then Maggie Martinez, I saw you were on this call, and I know you are a boarded pathologist of kidney interest. Are you able to unmute yourself?
I've got a baby in the background, but yes,
That's
I'm
fine.
able
I love it. I want to say hi to her.
to.
So if I tell you this is a glomerulus, you would agree with me, correct?
Yes, I would agree. That's a glomerulus. His baby.
Okay.
You got 2 pathologists for the price of 1, actually.
Oh, hey, Michael, how's it going? So what is the first thing that strikes you about this glomerulus?
I'm seeing a lack of capillary loops in that glomerular tuft, and I would very much want to see some special stains because I can't tell if that's like glassy material or if it's something that might be more interesting on like a trichrome.
Okay, great. Okay, awesome. So we have extra material that is kind of obliterating, it's compressing and narrowing the capillary loops. And so we're looking only at an H&E and realize that when a lot of these pathologists that are at standard diagnostic labs only look at things on H&E, they might kind of think, oh, is this just sclerosis or is this extra material that's not supposed to be there? Here is what, I mean, even this is a little bit abnormal of a capillary loop, but I'm circling one area. It's a little bit too thick. It has like 4 nuclei, although we're at the base of the tuft. But that is kind of, we know that's an open capillary. And then we know that this thing right here is probably an open capillary. But then as Maggie said, a lot of these capillaries are not open, they're not patent, and they're not being able to be perfused. And then we have extracellular material, and then we just have a few nuclei hanging out here. And so we'll go to one more glomerulus and see if this is repeatable. And so we go to another glomerulus and we have, again, some extracellular matrix, doesn't have a lot of cells in it. And there's too much material here. And so the pathologist very astutely requested extra stains, and let's hopefully that they're loading. Is there a specific stain you'd like to see, Dr. Martinez? Dr. Martinez
Martinez would like to see a trichrome, well, always PAS, and
Okay.
then but first,
Trichrome.
yeah, I want to see if it's
Okay,
one
let's
particular
see.
thing.
Of course, it's gonna not load. That is the Jones. Here, this one's. Oh, no, don't close. You know how like when it's in the little bit of the way for the sharing thing. Oh, here's the PS. Okay, here's the PS. I can at least load that one really quickly. We're gonna go back to those same glomeruli. And this is that first one we showed you. And we have material in it, and it is kind of, you have that kind of a dense pinker area, and then you have a little bit of a paler pink area in the middle. So that's one glomerulus. So that's the Jones. Go to the trichrome.
You can go to the Congo.
Okay. So, okay, for the clinicians that are in the room, I want you guys to put in the chat. Dr. Gordon must have gotten knocked off and is getting readmitted. So anybody, please put in the chat, what are we looking for when we stain a kidney with Congo red? This is actually a question that would be on a nephrology board's exam, because this is a very classic thing that we would want to talk about. So even if you are not a pathologist, you should be able to know what we're looking at when we're looking at something for Congo red. Is anybody putting anything in the chat?
Yes.
Okay, what is it?
2 amyloids.
Okay, good. Okay, so we have suspicions when we see a lot of extracellular material and not a lot of nuclei, that it could be the presence of amyloid fibrils in there. And so we don't routinely run a Congo red on all of our specimens because we don't really need to. But once we suspect it, we will have the lab do it, and they can run it usually that next day, and we can get the result pretty fast. And so I was able to text JD the day the original ones came out, and I said, oh goodness, it looks like amyloid. This is a little scary because it's only a 2-year-old cat, and it's obviously a disease that we can't really reverse. And so I've said we're gonna request a Congo red, and actually the lab had already kind of picked up. Jessica's team is really good at identifying this, even without my expertise. And they had already requested it. The request was already in. So the Congo red is a stain that is called red. However, when it stains, it is this peach to orange, excuse me. It is staining the amyloid fibrils themselves. There is the verification of the stain, which I cannot do via digital slides, because you have to look at the slide with a polarizer on your microscope. So if it is ever suspicious and it's like not definitive, like this one is strongly Congo red positive, but I will have the lab go back and put the polarizer on the scope, and they'll take a photo with their phone. It's kind of like annoying to an onerous task to do. But it can help me when I'm like, oh, is that possibly amyloid? I'm not really sure. But this peach stuff is peachy orange stuff is consistent. And what if I did that? Nope. I don't want you there. I think this is annoying, the little zoom thing. Oh, that's what I wanted to do. Hello. All I needed to do was move that window. Okay, we'll show you what the trichrome looks like. The trichrome is a stain for collagen. So if you guys can see, there is a difference between this blue here and the blue of the glomerulus. So the collagen blue, true collagen fibrils will be this kind of darker blue color, maybe bright blue, whereas amyloid fibrils will be this kind of pale, hazy blue. Sometimes it can be even a little bit orangey. So there's a lot of variability in the way trichrome will show this material, but you can clearly compare it to the collagen that's in the interstitium and realize they're different colors. And so the trichrome is very helpful for that. And then the last stain that we also do is a Jones. And the Jones is a stain where the material should be this Jones is a little bit dark, but if you had glomerulosclerosis, the actually truly extracellular matrix that is native to the glomerulus, it'll be dark. And this one, it does stain a little bit too darkly. But there are regions that are just more pale gray, and that's what we usually see with amyloid. So some of the amyloid cases we'll have will be like very, very light gray. I think this one's just a little dense. Every day is a little bit different, the lab. Okay, so then quickly, I do want to go back to the Congo Red because I want to ask one more follow-up question. I want everybody to kind of look and make their own opinion first before we move on to the EM, which Dr. Hokamp has just sent me images via her phone. She is currently down on the EM scoping this real time. So I have her EM images. So I want everybody to look inside the medullary region and kind of take a thought about if we said all of this material. I mean, I'm not doing anything. This isn't like earth-shattering science. But if I saw this material in the glomerulus and I knew the glomerulus was at least moderately affected, then
not something important to be studied.
I will look in the medulla and I will see that there's still kind of orange material as well, and it's separating the tubules. So the additional diagnosis for this particular cat is medullary amyloidosis, and it's probably mild to moderate based on the Congo Red stain. So that shows or indicates that not only does this cat have evidence of deposition in the glomeruli, it's also present in the tubular interstitial compartment or the medullary interstitial compartment. We always check the vessels too to see if the vessels are affected. They were not. There aren't that many vessels. I think there's vessels in the other sample. This is kind of background stain we see with any kind of collagen of the artery. And so the vessels were not affected, but the medulla was, which might be kind of the reason that she's actually doing fairly poorly. Is not only do we have glomerular involvement, we also have tubular interstitial involvement as well. There's also background tubular interstitial scarring, background tubular interstitial nephritis. And so that is kind of all compounding the disease process for this little girl. EM, do you want me to show the EM really quick, JD, and then you can talk about the rest of the case? Okay. So as I said, Dr. Hokamp is bringing this. I wanted to stop sharing. Okay. She's showing me, or she took pictures just now, and she might be texting me even more as we see. Okay, you text. Oh wait, hold on.
Hey Rachel, while you're looking at those, there was a question about subjective, or say a statement in the chat saying subjectively this seems like a lot, considerable glomerular amyloid, but I haven't seen a lot of renal amyloidosis. How does this compare to other cases folks have seen? And then also, is there significance to amyloid concentrating in the glomerulus versus the interstitium? And do you ever see one or the other?
Okay, so I'll answer the second question first. The interstitium versus the glomerulus. So we often say that a typical dog amyloid case is usually glomerular, and it is not commonly in the medulla unless they are a certain breed, which is usually Shar-Peis. So Shar-Peis can have medullary amyloidosis, and then also have it in their glomeruli. But other dog breeds usually is just glomerular limited. Cats are more likely to have it in, they have a higher propensity of it having in both places. Sometimes we'll have animals that will only have it in the medulla and not have it in the glomeruli. And then also cats, especially in like colony cats and cattery cats, they have a higher incidence as well. And I think that's recently just been published from Italy. I think whenever I had an autopsy of a young cat from a breeding colony or a breeder, I would always worry that they had some kind of amyloidosis, and I could usually detect it. It might be mild, but I often found some. So that might be a stress factor that might be elevating the risk for that. This is, I characterize this, I think, moderate to severe. And for the glomeruli, we kind of came up with during the WSAVA kind of group, we didn't really know what the best characterization for scoring it. So our score, or our ways that I kind of still use to this day, is that if most of the capillaries are still patent, but I can see the material, it's mild. If the glomeruli are often effaced because there's amyloid in those regions, it's at least moderate. And if all the capillaries are effaced, then it's severe. So we get a lot of moderate to severes for a lot of our cases. We do have a pending case right now from AMC that's a mild. So we have one of the few mild cases that we get to see. So that's my grading system that I typically use. So if it's, you can still see the capillaries in most of the gloms, then it's mild. And there have been 2 or 3 cases where we didn't detect it until we did EM, so that would have been minimal. But seeing capillaries still patent is mild, having capillaries partially effaced or having capillaries effaced by the amyloid is moderate, and then having all the capillaries effaced and the whole glomerulus is basically just a ball of amyloid, that's severe. And so a lot of them fall into the moderate to severe category. I've also seen cases from autopsy cases where only like a third of the glomeruli had amyloid, and I have no idea how that happened because in our minds, amyloid is a diffuse disease. So in our biopsy caseload, it's almost always every single glomerulus has been hit, but I have seen a few cases where it's just, and it's conga red positive, and it's only in like maybe a third of the glomeruli, and I can't explain that one. Any other follow-up questions for that? I think Maggie had another comment. Yeah, again, wildlife. Yeah, Maggie does wildlife, so she gets to see a lot of variations of it. Okay, let me download this last one picture and I will quickly bring up my photos. So this is a snapshot from let's see, how do I want to do this? From the Dr. Hokam's phone. And oh, why is it doing that? Hold on. Share screen. Okay. And then I want to bring up the photo. Okay. Hopefully you guys are seeing a photo. Yes. That's an EM. Can somebody tell me? Somebody tell me?
Yeah. Yes.
Okay.
Yeah.
Okay, so and I have a few of these, so it'll take just a moment to load, but there you can, as we're orienting ourselves to EM, for those of you who don't look at it that often, this right here is the capillary wall. And I wonder if I can annotate. Let's see if I can be a little bit better about this than Dr. Foster. Okay. I'm going to draw, this is the capillary wall. Wow, look at me. Look at that. So that blue is the, oh, now it made it pretty. Okay. Inside is the capillary lumen. And then let's make it bigger. And I want a different color. Let's make it red. So, oh, now I feel like an idiot. I was giving myself so much credit and then I made it a little bit. So this stuff here is all the amyloid, and this is basically within the mesangium. So the capillary wall of this particular capillary looks like it's pretty good. It's not really yet in the basement membrane. Sometimes you'll get amyloid fibrils within the basement membrane. This is probably a little bit of amyloid fibrils kind of along the basement membrane, right, as the capillary is growing out of the mesangium. But all the mesangium is expanded by this fibrillar material. And so when we have to go a little bit closer to see what that fibrillar material is, stop sharing that. No, because I need to go back to here. Library. Here is another one with actually a lot more material. And actually, I think I like this picture you sent better. Hold on, let me download this.
The most recent, the second one I sent was better.
You have an echo. It's kind of fun.
I know it's the fact that I've got multiple things going.
Oh, do you have like your, okay, I'm airdropping it, I'm receiving it, I'm opening it, and now I'm going to share. Share. Screen. Okay. Hopefully you guys are now seeing another one.
Yep.
Okay. Yep. So this is a zoom in of the actual material that I kind of squiggled. And so the amyloid itself is usually 9 to 11 nanometers in thickness. And it's usually haphazardly arranged fibrils, so you can just see them almost like pickup sticks. If you guys remember that game from whoever children played that game. Sometimes they're a little bit curvilinear, but they are haphazardly arranged. They don't branch. And so all of this stuff that is these kind of circular things here, these are actual just little bits of cell fragments right there. So you have like a little bit of cytoplasm or whatever that's in there. This guy over here is probably a part of a nucleus. Move him over here. But then all the extracellular spaces are expanded by the fibrils. And I think, Jessica, are you still scoping? I'm not going to ask you to do this in front of everybody, but I think it would be interesting because the other differential that we had for this case, being such a young cat, is a problem when they have abnormal collagen synthesis. And so I think it would be interesting to see do you see these kind of like more like linear arranged, thicker fibrils, Jess? If you could try to see if there's any more spots that have that. That might be kind of indicative that she's got not only amyloidosis, because this is the right side of amyloidosis, it's definitely congruent positive, but she might also have abnormalities and like a little bit too much collagen. It actually looks like more of a fibrillar collagen in that little area. And so maybe that's kind of a little bit, maybe it could explain a little bit why the silver stain was also a little bit darker than we normally see. But I'm kind of getting this impression, this is kind of fun to do in real time, just to tell you what to scope is. That these areas here where the lines are kind of going parallel to one another. If we could get more examples of that, that'd be great. And so
Okay, sounds good. I will try.
And the other issue, or not issue, but as we go through this particular case, if we find good evidence of that scenario of having a little bit more collagen than normal as well, obviously it just means she's kind of got overproduction of collagen and production of amyloid fibrils. So that's bad news for her. We don't normally see those two co-occurrences, so that's why I want to get a higher mag. And then it might also be worthwhile just like after the new year sending me the grid so I can scope it. My scope at OSU I can do really good measurements with, so I could actually get an estimation on how big those fibrils are. They look like amyloid fibrils based on my view of a picture of a photo or whatever. They're the right thickness, but there might also be intermixed additional fibrils kind of in there. So it might be one that it would be worthwhile to send to me so I can measure those fibril thicknesses. Okay, so just to bring along that little twist of a differential diagnosis. So this is a young cat. It is proteinuric. It has azotemia, and kind of wasn't doing all that great. Wasn't just trucking along with its mild azotemia or moderate azotemia, I guess, at that stage. And so the differential diagnosis for amyloidosis, when we're seeing all that matrix, is a dysregulation of the type of collagen that is made in the glomerulus. And so you should have only type 4 collagen in your glomerulus in a mature glomerulus. She should be mature, but there is a disease phenotype where animals and humans can make too much type 3 collagen. And so type 4 collagen is a basement membrane collagen, and type 3 is a fibrillar collagen. So that means that all of a sudden you'll have these like fibrils that they don't look like amyloid. They're thicker than amyloid. They run parallel to one another. They have cross striations. And we call that type 3 collagenofibrotic glomerulopathy because it's a lot of collagen. It's actually making fibrosis. It's not making amyloid or anything like that. And we've documented it in cats, we've documented it in dogs and in humans, and I think monkeys, and I think it's in a squirrel or something, maybe a lemur. So it is a dysregulation of the type 3 collagen. In humans, they kind of do know some of the underlying genetic variations that predispose to that. They've looked in dogs because we have been able to identify a certain number of these in dogs, and I think the lab that had looked at it had also looked at cats, and they haven't been able to find a genetic similarity for any of those. So we don't know why they overproduce type 3 collagen based on the amount of analysis that's been done for genetics. But it would be interesting. So
hey, Rachel,
yeah.
Given that the special stains in that case would be different, the trichrome, especially the Congo red, is that something that you're thinking could be like intertwined with amyloid, or Do you really
Yeah,
think the
so I
collagen
don't know if
3
she's
would-
just making like a little bit more than we would actually think. And I don't know. I mean, so to be clear, occasionally a degenerating glomerulus that's undergoing sclerosis can make fibrillar collagen. You occasionally, like you'll see it in just bad sclerosis, you might see fibrils like that are cross-striated. And so you kind of just, but you know it's undergoing scarring. So, but her Jones was a little I don't know if it was overstained or if that's why the Jones is picking up that kind of collagen that's admixed with the amyloid. Because usually a Jones should be pale gray in the mesangium, and that one is black. So anyway, so you can technically see occasional striated or fibrillar collagen in a glomerulus that's kind of basically completely gone. But as Mary says, the true collagenofibrotic glomeruli, they have a different tinctorial change to their trichrome. It's actually a bluer trichrome. It looks more like collagen. So the staining pattern for this is not really classic for either, and we do see definitive conga red positivity. So we know there's at least amyloid in there. It's just whether or not there's something else intermixed. JD, did we just break your brain?
No, not at all. I'm pumped.
So she's not doing that great, right? Is she still with us?
Yeah, she's still with us. She's hanging. I mean, honestly, the biggest problem that she had was she got an E-tube site infection. I popped in her E-tube and I started her on steroids, hoping that she had an immune complex glomerulopathy. And then she came in the next week with her E-tube site looking pretty gnarly. So she's been doing okay. Her kidney values had been, they initially went up and then they came back down once she had, on antibiotics and she was feeling a bit better overall. So she's kind of plateauing, and the last time we checked her creatinine was 3.5 still. So she's hanging in there, and I think as long as we can keep her happy, this is certainly not an acute thing. And she came in for, I don't know, maybe some symptoms that could have been related to her mild azotemia. Maybe there's still some oral pain that we need to deal with, but now that we have more information, now it's just a matter of making sure the E-tube site infection is behind her, and then we're just going to manage her as we would with any other patient with chronic kidney disease. She's already azotemic, so the utility of other therapies at this point is going to be certainly much lower.
Is there any possibility with the anemia, because you said you're not entirely certain if it was from chronic kidney disease, that maybe she's got something in her bone marrow that's making too many amyloid fibrils? Like, do you think this, I mean, we can't tell if this is light chain amyloidosis or serum amyloid A. Like, we don't know.
Right. It's possible, although she does not have any other cytopenias that would match with just having an anemia. Her abdominal ultrasound was otherwise fairly unremarkable. She didn't have any lymph nodes that were enlarged. So granted, there could be disease still in her marrow, but it would be a little bit funny if she had myelophthisis to only have an anemia.
That makes sense.
3% without any other cytopenias.
Yeah. And so that was a reference to, in humans, most amyloid cases that we see in developed countries are due to usually a lymphoproliferative process that's making too many light chains, and so the light chains become the amyloid fibrils. We do not see light chain amyloidosis in cats and dogs. There is a variation of light chain amyloidosis that can happen in horses, but I should say we do not see renal amyloidosis that's due to light chains in dogs or cats. I've never seen one. That being said, the amyloid will look like amyloid will look like amyloid will look like amyloid, and the only way you can actually truly differentiate it is if you stain and you see positivity for one of them, you do mass spec and identify the overwhelming amount of light chains in their kidneys as well. That's a possibility. But if you do mass spec and you identify that there's serum amyloid A, that's not supposed to be there. So that's how we know a lot of our cases that we've actually done that on are truly serum amyloid A proteins. I think there is a serum amyloid A immunohistochemistry, but I don't think anybody runs it. And I'm not sure if it's been validated in dogs and cats. So we just assume because most of them have been serum amyloid A, that most of them are going to continue to be serum amyloid A. But as Maggie has worked with us for different kinds of species with amyloidosis, she did the literature review, and there's tons of proteins that we know in humans that can be synthesized and in a way that they are predisposed to making amyloid fibrils. And so we just haven't been able to isolate those proteins out of dog or cat kidneys to date. That also kind of leads me to one more thing. So as far as when people are talking about distribution of amyloidosis, I've seen human cases of amyloidosis, which is basically just vascular and not even in the glomerulus or in the medulla. And I've also seen some that not only are vascular, but just at the hilus of the glomerulus. So it's like basically at the afferent or efferent arteriole, blown apart by amyloidosis. And the glomerulus looks like completely unaffected. So there's just, who knows, why did it decide to go there? I have no idea. But you can see some very weird pattern distributions if you look at enough cases and get enough biopsies accumulated. So, are there any questions about this particular case? I guess I will quickly say Dr. Foster was surprised because the cat is young. And like I said, we had kind of been tossing around this idea of maybe it being collagenofibrotic. I got back to him as soon as I could to tell him it was Conga positive, so it fit with amyloid at least. And so I did quickly look at our other amyloid cases. We actually only have 6 amyloid cases in cats. I don't think people submit a lot of amyloid cases to us. Sorry, Dr. Hokamp is texting me right now. And I think like 2 of them were less than the ages of 3. And the other ones were older than 6. So this would have been our 3rd cat that was about, like, the other one was like 2.5. And then we had a 2-year-old, and then we have another 2 and 3 months or something. And the other ones were 6. Yeah, that's great, Hokamp. Wait, maybe. I need to measure it. It could also just be those spike formations that we see sometimes. You're gonna have to send me the grid. I'm sorry, this one won't be a clear cut right now. One other thing. So we can see them in young cats, and I'm not sure, is anybody, I mean, or you guys still, what are you treating amyloid with these days? I know we've had a few of these cases, but they've mostly been dogs. Just management?
Yeah, standard of care for the most part. We've long used colchicine. I think it stems back to Cowgill standing up at a meeting and saying, hey, this is what they use for Mediterranean fever in people. And then everyone latched on to his words of knowledge and have used colchicine forever. Colchicine actually in people does not have the study to support for our type of amyloidosis that we see in our patients, that it actually is improved with, it improves their survival. People can improve with a prosidate, and they can have improvement, which is a fibril inhibitor, and also cyclophosphamide as well. So I'm not aware of any data of a prosidate in cats. Certainly cyclophosphamide is something that we could consider, but we got to get this cat's E-tube site infection well behind her before we would even consider that. I think probably chances are more likely that we won't use it, and we'll just continue to give her supportive care. And she feels, I think, generally well now, and she's back to more like her normal self. So I think we'll probably just ride it out and hope that we can keep her in a good place. I mean, her azotemia is fairly mild and she's young, so that's probably the best thing for her, is that she might not remember the year of her life that she had a creatinine of 1. Hopefully this becomes baseline and she feels all right.
Yeah, hopefully. I hope she has a comfortable, relaxing holiday. But I will get this report out to you, and then we'll get the grid here. Well, when I go back to Ohio, so I'll probably just write a revision. Just has the thickness of the fibrils. It's not going to change anything clinically for you, but it would be good to know how thick those fibrils are. So,
great.
Because I think there is a way to technically measure with the EM scope at Texas, but nobody has done it routinely. So, whereas our OSU one, it's like you just do it while you're scoping it. You immediately measure the fibril. So, and it's just all, I don't know, science. Okay, well, we are at the time. Thank you for this discussion. We will have another invitation go out in the early January. It looks like January's third Tuesday is the 21st. So we will send out an invite to see if anybody wants to present a case. And like I said, we can do a very quick discussion if you want, if you don't want to have to do the full presentation. But and also you can do urinary bladder samples, ureter samples. We are taking a lot of that other stuff now. We get most of ours from Friendship and from Colorado ASC, Dr. Gordon's practice, Dr. Gordon, Dr. Creighton.
Case.
Yeah, so we've been getting a lot of them, and if you guys have any, if you want to have us present one of those too, we're very happy to, because it's kind of fun to talk about something else too. Okay, I will see everybody hopefully in the new year. That sounded, I will see everybody. Have a good year. Bye.
Bye.